Each week we talk to interesting people from across the HLA community to share with us their ideas and their innovations and hopefully bring them to a global audience. Many of the topics come from our community, with scholars and faculty expressing an interest in many of the discussions that we're about to have. HLA programs are built on 6 pillars. The leader is an innovator and entrepreneur, the leader is a communicator, the leader is a manager, the leader as a negotiator, the leader as a follower, and the leader as a philosopher. If you are interested in becoming a HLA scholar, why not get in contact? Many of the episodes in HLA Live will cover one or more of these important pillars. The HLA team consists of Pedra, Eamon, Tim, Riddy, Alistair, Adil and Trisha, and a range of other HLA scholars and faculty.
Hello and welcome to this evening's HLA Live episode. My name is Patricia Vincenzo and I'm a final year medical student at Queen's University and I'll be the host this evening. Today's discussion panel will be on secure setting and prison healthcare, and I'm joined today by Dr. Jake Hard, Kate Morrissey, Chantel Edge and Dr. Radha Kathari. Without further ado, I will ask the first question to the panel. First of all, our first question is, how has secure setting and prison healthcare changed over the last 10 years?
I suppose I should probably start with this question. Having worked clinically in the prison setting for about 14 and a half years, I've seen some really dramatic changes. To give you an example, when I first started working in prisons, you would be working out of paper records, which when you compare it to primary care in the community, they already had computers and were doing a lot of their physical health care and mental health management of patients with the use of computers. We've had prison IT systems for about 9 or 10 years so far. So that's one of the biggest changes I've seen.
For me, it's been the transfer of the responsibility for prison healthcare commissioning from what was then the National Offender Management Service to NHS. So it makes sure that absolutely that the patient is at the centre rather than the security element.
I guess I think that's the biggest change that I've seen as well, that the NHS is leading on things now.
And I would add to that the emphasis is now much more, as Kate says, on the patient, and that really helps focus our minds on equivalence and how we can provide more equivalent care to people who are in secure settings and in prisons relative to the care that's provided to the wider population. And I think when there's when it's commissioned via the NHS, it feels like it should be the same as the NHS, but in fact in prisons things have to be done slightly differently because of the constraints, the 5-meter wall, the security elements and other things. But certainly the focus and the emphasis is on delivering something which is equivalent to that's available in the wider community. So it would also lead into being able to continue that care after you leave prison. So it should just connect, hopefully one day seamlessly with that in the community.
Sorry, go ahead.
So in addition to that, I think, absolutely, as Jake says, continuity of care when you've got NHS talking to NHS commissioned services really makes sure that there's that focus on seamless transitions. And also we've massively, as NHS England and NHS Improvement, invested in those points of continuity. So for example, we have rolled out 100% geographical coverage of liaison and diversion services, so diverting people at the first point that they come into the criminal justice system, at their very first contact, where it's appropriate, diverting them out of the criminal justice system and into appropriate treatment. But also where they are required to go to prison, to make sure that there is that liaison and that their healthcare continues. We've then built on that with the community sentence treatment requirements. So we have mental health treatment requirements, and we're working with MOJ and Public Health England regarding DRRs, so drug rehabilitation requirements, and ATRs, alcohol treatment requirements. And we've invested heavily in that. Plus our newest commitment within the long-term plan, which is the Reconnect service, which I lead on, which is a service that works with people pre-release and post-release to engage the most vulnerable back into community-based healthcare services. So we have an oversight of the whole care pathway rather than just kind of seeing our responsibility end at the prison gate.
Would anyone have anything else to add onto that point, or should we move on to the next question?
I guess just broadening out from the healthcare and to something more generally that I've observed, at least in the last 2-3 years that I've been working in prisons, is the change in the kind of demographics and profile of all the staff working in prisons, which makes it easier to engage with them as a healthcare body. So you know, even the younger prison officers and the newer prison officers coming in are far more interested in rehabilitation. They're far more interested in understanding more about mental health, at least I'm aware. I don't know so much about physical health, but certainly about mental health. They're craving training in mental health, and they're wanting to kind of be more focused on rehabilitation than the kind of stereotype of the officer who is very much about discipline and regiment and things like that. And that's great. Unfortunately, at the moment, we don't have the resources to support that, and it's not supported well enough. So what happens as a result is that you get a very high staff turnover, because you get lots of new officers and staff coming in who are very keen to make change and very keen to rehabilitate, and very keen to kind of engage in training and reflective practice and clinical supervision. But because there isn't the ability to provide those things because of the pressures of funding and time and all those things, a lot of them end up leaving, which means you end up with quite an inexperienced workforce. It can be really limiting.
I've add to this, and I can't say it's from my own experience because I haven't been working in prisons and I haven't been in the field that long, so I can't reflect on it from my perspective. But in my research, I've interviewed quite a lot of prison clinicians and prison leads, and I remember speaking to one clinical director of quite a large prison service who said very clearly to me that always the prison service is changing. There's always this level of change of prisons changing from one type of category to another. They had a prison that suddenly opened from being a male prison to a female prison in a matter of months, that they had to turn around and get ready, that there'll be a political emphasis on don't sentence people and send them to prison, and suddenly it swaps to sentence people to longer, make prison sentences worse. And they said actually delivering within that constant change, it's really hard sometimes to plan ahead for what population you're going to be looking at. Are you going to be looking at people who come in and out of courts? You're going to be looking at people that are staying for a long time, and men or women or different health needs. So actually it's a constant change, and that's a constant battle for them to stay one step ahead to deliver to the need of the population they're serving.
I'd add to that for me, prison health is really exciting because you get to do a bit of everything, and you really never know what each day is going to hold, and you can have a great plan for the day, and it's all thrown into complete chaos by something happening in the prison, something happening externally. And so for me, it's just that it opens up so many possibilities. It makes you think on your feet. It makes you kind of have dynamic risk assessments to be really thinking about, okay, so I've got this change, what can I do to get around it? How can I adapt to overcome and make this work for the patient?
I think, like you're saying, Kate, as well, isn't it? It's the fact that you're delivering healthcare in someone else's domain. You know, everywhere else you're the NHS, and you're the NHS in the hospital, and the NHS in the GP surgery in the community. But here you're the NHS in HMPPS's world, and you've got to make it work within that. And I think that's part of the ever-changing plans, isn't it?
I should probably also mention, I mean, I've been very heavily involved in the introduction of the health and wellbeing model of care, which is currently only being kind of developed in London at the moment, with a plan to roll it out in the rest of England. And that's very much about making all the different kind of teams that would provide support work together and be more holistic. So kind of reduce silo working and have like a single point of access and all that kind of thing. and that's, you know, that's been really interesting developing that, because it develops very different inside each prison, because each setting is completely different and you've got a different population and different teams within that. But also it's really highlighted more than anything else the amount of need. So, you know, we went in thinking, okay, we've got an increased number of people in the team, we've got an increased number of professionals, and I guess I'm speaking more from a mental health capacity rather than a physical health. But really from that single point of access and through increasing kind of awareness of the available services, where we've ended up in a situation where need still way outstrips provision, because we're far more aware of how much need there really is. So yeah, even this kind of approach to having a more holistic model of care has really, really highlighted how much need there really is.
So what are the current challenges of delivering healthcare to these individuals within secure settings and care after custody?
For me, there are lots of challenges. So when you're in a prison, security is always at the forefront of your mind. And so, you know, some of the real challenges, particularly within the COVID-19 pandemic, when we've had people isolating, staff off sick, is that you need to move people around the prison, you know, to get, so it's not, people can't necessarily come to you. You're relying on a whole number of factors to take place to get that person to the clinic door. So, you know, they have to be, one, informed it's their appointment so that they don't go off to work or don't go off to the gym. Two, someone has to inform the officers. The officers then need to unlock the door. That person might need then escorting through 5, 6, 7 locked doors to get to the clinic room. And then you need to engage with someone in a clinical setting with a therapeutic relationship in a really difficult, challenging environment. And, you know, you have a really limited period of time. They might be resentful that they've missed their gym or they've missed going to work just to come to see you. And so that's a really significant challenge, actually just getting people to the door and then really having to engage with people really quickly to build a relationship, to manage their health. So that's one of the things that we're always kind of working with and against. It's not like the community. People don't tend to just DNA just because they forgot their appointment. They could very well be remembering their appointment but be unable to get there because, you know, the prisons that don't have the staff for the pandemic, or someone forgot to inform someone else to get there. So there's lots of challenges kind of practically, as well as the challenges in organisational structure, as Chantal very clearly said earlier, you know, working in somebody else's house. You have to negotiate and work to their rules to a pretty extent, and often advocate strongly on behalf of your patients.
I think to add to that, I mean, I find working in prisons particularly interesting because of the kind of different subsystems interacting all the time within the larger system, and also the fact that you are constantly in a very high risk environment. So everybody, and that goes for both prisoners and for the staff. So everyone's in a slightly kind of threat focused mindset, let's say, which makes it a place where, you know, all communications can be slightly biased by that kind of threat focused mindset to be, you know, I guess they can be easily triggering for both prisoners and for staff. People are quick to react, and it creates quite a reactive environment. And because it is so busy and so high pressure, that reactive environment, there's not really time to take out to reflect on that. So one of the big challenges, I think, is trying to move a prison from a system where it's a very reactive, threat-focused system to one which is more reflective, where people can consciously act and consciously reflect on how they're communicating with each other, how they're communicating with their patients or with their service users, and generally how they're communicating just as they walk just through the prison, as they're, you know, moving around and things like that. So it can be quite a high pressure space to be in generally, which makes it difficult to create those therapeutic relationships and have those, you know, really kind of compassionate and containing conversations, I guess.
Yeah, no, I was just going to talk about, so there was a piece of research I did, which Jake was also involved in, around hospital care. So slightly more specific. And this was actually driven by conversations I had with a lot of hospital staff where I'm based in the southeast, and their lack of awareness around what it was like coming from prison going to hospital. And actually, when you explained to them what it was like going from prison to hospital, they realised that they needed to do things a bit differently. And actually, it wasn't the way they liked to provide care to patients. So when you explain to them that people aren't allowed to know when they're going off site, that poses a security risk. So when someone has a hospital appointment, they don't know that they're going to go. They don't know when they're going to go. The fact that people have to go out with prison officers, so there aren't enough prison officers to take every single person who needs to go out, you know, in a timely fashion. So people, I'm sure Jake can talk more about this, but people get prioritized or moved around on the list. So people can wait a really long time for their turn to go out to hospital, unknowing when they're going to go out. And then when they do go out, it's exceptionally stressful. You're with the prison officers, you're in handcuffs, you go to the hospital, people are staring, the doctors might talk to the prison officers, not to you. The prison officers might be in the room with you during the examination or listening to your personal information. And then there might not be a really very good option to hand over clinical information to take back to the prison healthcare team from the hospital. And people find that a really, really difficult process, understandably. And again, once you explain it to hospital staff, and I've spoken quite a few times to junior doctors about the research, and all of them have said, you know, we didn't know it was like that. We thought people in handcuffs meant that they were really violent. Everyone who was in handcuffs was really violent. We didn't realize that everyone had to wear handcuffs. And it's something we don't get taught about and we don't know. So actually sort of raising awareness around those issues of going to hospitals is something I think that's helpful for staff that don't work inside the prisons. And that's actually a challenge in accessing that hospital care. Like I said, Jake probably has more to add from that perspective.
Thanks, Chantal. I suppose it's been sort of outlined before that we're doing something in somebody else's house, and the prison service is responsible for security of the individual at all times, whether they're in the wing on the prison or should they indeed need to go out to hospital. And so this is one of those areas, really sort of acute areas, where your medical advice, my medical advice, that this person needs to go out to hospital for, let's say, a routine appointment to see an orthopedic surgeon, or as an emergency because I think they've got appendicitis, I'm actually brushing up against the governor of the prison and saying, you need to change your approach to security for this individual and take them out of this secure location. So you've got to be, on one hand, pretty minded that there's a need to do that, and especially with emergency situations, which might be late at night when the prison has less officers around. It can become quite complex, and you can be obviously put under the spotlight and challenged by governors. Really, does this have to go now? And so you have to be confident in yourself medically that you're doing the right thing, and the right thing for the patient, obviously. I occasionally, just throwing it back the other way, I have had scenarios where the governors have mentioned to me, well, actually, we've got some intelligence to suggest that this person is trying to get out to hospital because they've got a parcel coming and they might meet somebody at the hospital to give them some drugs or a phone or something like that. So you've got to weigh all of these things in the balance. It's not just about making a clinical decision in this case. You're working very much with the security of the establishment and on behalf of them in some ways. And there's that triangle between the patient, you as the clinician, and the people that are responsible for security. It's quite complex.
And that conflict between care and control is just constantly there as well. It's, you know, we come from a very kind of compassionate, caring, wanting to provide wonderful, you know, community level care, and we're essentially pushing up against a completely different agenda, which is more about, you know, managing risk and making sure that the discipline is at the center so that everything can run at the right times, the right pace. You know, the regime comes first always, you know, so you can't keep someone for 5 minutes longer if that's going to interrupt the regime of the prison. And it makes sense because everything knocks onto everything else. And, you know, something that's slowed down over here for 5 minutes can cause massive disruption over there. So it makes sense, but you are, as you say, in someone else's house, and that causes a massive, I guess, there's a resistance, I guess. You're always trying to work with rather than against, I suppose. And that's definitely the case with unexpected transfers of prisoners from one prison to another or one institute to another. The continuity of care is really quite poor, I guess, between prisons, I think. And as much as we try to provide a continuity of care, you know, we will send, you know, information on to other prisons. We will try and kind of make sure that everybody is in the loop with everything that's going on. But certainly, you know, people who come into Pentonville who may have been halfway through a therapeutic intervention at one prison won't necessarily be able to continue it immediately when they arrive at Pentonville, or, you know, vice versa. They will end up on another waiting list. They will end up with another clinician, and they will have to build that trust again. And that's very difficult for a lot of the people we see, because they have very, you know, lots of trauma in the background and lots of kind of reasons not to trust professionals, but quite legitimate reasons not to trust professionals often. So it's difficult to provide a continuity of care when actually we're dealing with something that is more focused on where prisoners should be based on risk and sentencing and things like that, rather than actually the health or the mental health and care of the prisoner.
I have to say, for me as well, people come in and they're really often quite poorly. So we're talking about people who have really not been engaging in healthcare within the community in a lot of cases. They may have addiction, severe mental health problems, and they will come to the prison and you have to manage what's in front of you. And that needs to be, you know, you need to be able to see that. But also, kind of, for me, the opportunities that this presents as well, absolutely, you know, that's what makes working in health and justice settings for me really exciting. You know, you have opportunities that you wouldn't have externally in the community. You have the mental health team based with the primary care team, with the substance misuse team around the same table, having those discussions. You can have multidisciplinary meetings at drop of the hat. You can put in place joint care plans without having to send a big long letter of referral to another organisation waiting for it to come back. So there are some real opportunities, and you know, there's nothing better for me when I go into a prison and I see someone who's really, really poorly, and then you go back 6 months later and they've put on weight and they're engaged in their treatment and they're saying, come, like, this has saved my life. That to me makes it all worthwhile. And yes, there were a lot of challenges, but I really think we can't forget the opportunities and how, you know, those interventions at a point when someone's at their bleakest, at the worst time, they've been ripped from what they know into an environment that might be completely alien, and the support that you give them can be the thing that turns their life around. And for me, you know, that's where Reconnect comes from, and the continuity of care and ensuring that people are able to maintain and safeguard the health gains they made in the community, encouraging them with lived experience support as well to engage back in those healthcare services in the community, to see the value of them, to feel the change within themselves and continue that in the community. Can you tell what I love health and justice?
I have to say, I feel like I was sounding quite negative there, and I really didn't mean to. I absolutely agree with you. It's partly why I love working in prisons as well. It is an absolute opportunity. You have this kind of moment, a brief window, don't you, in time where you can go, okay, let's sort it all out as quickly as possible right now, while we've got you here, so that we can set you up as well as we can before you go wherever you're going to go next. I know recently we had a review that talked about how currently, I mean, we set up an ADHD pathway now in Pentonville, and they said that you're far more likely to get an appointment, get assessed, get treatment, and also, you know, get a psychological intervention as well, far quicker coming into Pentonville within kind of 3 to 6 months. Whereas in the community, you're looking at 3 years to even get an appointment to look at that kind of thing. So definitely, I agree with you. There is a real window of opportunity, I think.
And you can't turn people away. You know, you have to deal with whoever is there. You can't say, oh, no, they're a bit risky for us, or, oh dear, like, we don't think you fit your criteria. You know, I'm sorry, that you need to manage this person and do the very best that you can for them.
Yeah.
Perfect. Shall we move on to the next question then? So how do we manage the specific mental health and complex needs of this patient group? Very broad and challenging question. Who wants to take it on first?
Well, picking up on what Kate said, actually, and thinking about how we've approached taking on this new health and wellbeing model approach, I think having everyone sat round the same table is absolutely a fundamental difference that makes it possible to deal with the complexity better inside a prison, at least. So, you know, every referral, it may be a referral for substance misuse, but we will be looking through it to see whether there are any physical health issues that need to be addressed, whether there are any other mental health issues that need to be addressed, whether there's any neurodevelopmental differences that might be pertinent. And we will essentially try and address all of those things at once, rather than taking that referral and going, okay, we'll just deal with the substance misuse. And if anything else is going to be dealt with, it's going to have to be re-referred in. So taking that kind of holistic, everybody around the table and everybody's expertise, looking out for the things that they know might signify or might indicate issues of other kinds, has been, I think, really, really helpful, definitely.
I think I'm going to be Mr. Negative on this occasion. I think managing mental health and particularly complex mental health needs of the patient group is complex in itself. And if we take the patient pathway, you know, they may have contact with their GP, they may have contact with the community mental health team, they may have contact with the police, they may have been in touch with the liaison and diversion services, and then they may end up in prison and have contact with the mental health team, the in-reach team in there. And there is at the current time a real challenge about trying to capture all of that pathway and bring it together. And it's really difficult, partly because the sharing of information is difficult, and partly because prisons, in a way, for people with severe mental health problems, has become a place of safety. So the reasons for imprisonment are either to protect the public or to protect somebody from themselves. And unfortunately, people with severe mental health problems may commit offences and end up incarcerated before they know it. And I think that is not a good reflection of how well the services in the community are able to work. And I don't know what the reasons for that are. We could speculate about funding, and we could speculate about overlap of different pathways that I just mentioned. But obviously, when we've got somebody in prison, it's a real challenge, even if we can do something with them, to dovetail that into the community. And that obviously speaks to your programme that you're leading on, Kate, about Reconnect.
Yeah, absolutely. And I think for me as well, there's something around the benefits of being the NHS in this situation. You know, I think we know it's not ideal, and we know that, you know, people end up in prison when they really should be in a mental health hospital. But the fact that we're now the NHS and that we're now seeing the whole picture, we can push and have pushed. And, you know, we saw last year the independent review of the Mental Health Act, where it was saying prison should not be used as a place of safety. And I think that's testament to the kind of the fact that we've been able as the NHS, along with our partners, to push that agenda forward. And I think, you know, we know that we can do better, and we are striving to do better all the time. But for me, the way we manage it is around being trauma informed, but having the patient at the centre of our care, as Raja and Jake say, you know, having that multidisciplinary approach. You know, we're very aware, you know, if someone's reducing on a methadone script, then potentially their mental health may suffer as well. So we can put those plans in place. And also, one of the great benefits is there's no wrong door. So the service specification for mental health within prisons is absolutely that there's a no wrong door approach. So you could turn up at the doors of substance misuse, you won't be turned away. They will work with mental health. You can turn up in any of the services, a prison officer can refer you. You know, that's something that's really different to within the community, where you have to go via your GP for a referral to the services. In a prison, you know, absolutely anyone, including the patient themselves, can refer themselves into the health services. So for me, that's a really fantastic thing. But I think we need to get it right before someone ends up in prison. And that's why we are, as NHS England and NHS Improvement, along with the Ministry of Justice, really, really investing in community sentence treatment requirements and mental health treatment requirements and liaison and diversion services. And we know that these things work, and that they will support people and get them out of the system, or potentially, if they do have to come into the system, help us to manage it better. But I agree, I think we've got a long way to go. We're not there yet. but things like the additional investment within the long-term plan for mental health, that's not just for community mental health services, that's also for prison mental health services. So we are working as a whole together to achieve better mental health for the offender population, and also more parity of esteem.
I would echo what everyone says from a different side. So in my public health work, I've been working quite recently with an ICS footprint, so an integrated care system footprint on community mental health transformation program at the moment. And it is clear that they are working towards the Wonder approach, but they know they don't have it. And they don't have services that fit for these people with multiple complex needs, because it's not the majority of their population. So we've got these wonderful services that Rada and Kate and Jake are talking about in the prisons, but people are not getting that when they come out or before they go in, because the community teams haven't kind of got themselves up to that yet. And I think we need to move to really wrap around these people. They need to move to having some type of similar catch-all system for people that need, have a mental health problem and a substance misuse issue, etc. Maybe they're homeless as well, you don't know, and wrapping them up in the community. And that's a massively important part. Don't just push the services for these people once they're in prison. Community have a responsibility to be able to scoop them up as well.
I think to add to that as well, there is, as much as there is this attempt to have this holistic approach and have, everybody working together, and we do have that, we will have daily meetings and we discuss all the referrals, and somebody from substance misuse will be there, somebody from primary care will be there, someone from psychology will be there, somebody from InReach will be there, there'll be a representative of every team, and we will discuss each case, and we will consider where, which support is required, what order it should be, and all that kind of thing. But actually, and I know I keep saying it, but provision doesn't match the need, which means that somebody will end up coming into Pentonville 2 or 3 times, coming through that referral system 2 or 3 times before we get to them. And when we do get to them, they are absolutely overjoyed, because they do get this complete wraparound service. They, the substance misuse is working hand in hand with psychology and working hand in hand with psychiatry, and everybody's communicating excellently, and we can just talk to each other in corridors and email each other really quickly and be in the same room together really, really easily. But it's only when we actually get to a person that we can do that. So and that can take a lot of time, because there just isn't enough, provision, there isn't enough funding. And a lot of the people we work with will often say, it's taken 3 or 4 times for me to be here, to actually get that care. And I'm overjoyed now I have it, because I understand my trauma, and I've got a lovely psychological formulation, and I'm, off the substances and all that kind of thing. But actually it takes a really long time for that to happen, because there's just so much demand. So the approach is kind of still be there. There's not nearly enough funding for the number of professionals we need to really provide it for everybody.
I think the time point that you make there, Rada, is really interesting. And in my experience, having worked in prisons and substance misuse services in the community, including DRRs actually, sometimes building that relationship with somebody takes years, decades or more to get to a point where they're ready to change, able to change, everything's lined up. So, obviously we don't judge when we're dealing with our patients in secure settings, regardless of the offences they may have committed or may be charged with and not necessarily sentenced for. But I think building that relationship is really, really important, and not withholding your care on the basis that, okay, this time they relapsed or their mental health deteriorated. It's part of their illness or their condition. So you just keep trying. You have to keep trying, and eventually people make it, but it takes time. It takes a long time.
Thank you, everyone. And we'll move on to our next question. So is there a role for telemedicine, and how will this improve secure setting prison healthcare?
I feel like I should jump in on this one. I'll give you the little bit of the backstory. It was in 2016 where I was working on public health placement in the southeast, and I was working at a hospital, and the hepatologist there wanted to improve care delivery to the prisons. So there's a lot of need for hepatitis C care, and so in America they do it by video, oh, wouldn't it be wonderful if we could do that? And I said, okay, well, I'll try. And started speaking to the Health and Justice Commissioner from NHS England, who was in the area, and got introduced to GPs in the prisons, who then told me, you realise this is just not about hepatitis C. This is an issue for a lot more than hepatitis C, and we need to be able to access, and in this case, it was hospital care, for the reasons I talked about earlier, much more efficiently, and where we could avoid taking people out, that would potentially speed up their time to appointment, reduce their cancellations, and mean that those transfers that have to go out are free for the people that have to go out. And we're not taking it up when we could do some things by video. So I started working on that about 2016. We're now in 2020 and we've had a pandemic and it's changed the face of everything, and we've been able to roll out the video, but it was not going that smoothly up until this point. Let's put it that way. It was a hard, tricky thing to do, because getting digital technology into the prison service under a format that's approved and secure by the digital oversight teams from HMPPS is not quick, because they have a lot of concerns around people who are cyber enabled and could mispurpose or misuse the technology. So it was a long process to get that approved. And now pandemic has fast forwarded things massively. So telemedicine was rolled out between March and October. Most of the equipment and the software rolled out across the prison estate in England, and the children's estate and the immigration removal centres, and that included all the work that HMPPS had to do to approve it and to assure it. And they did change the law in 4 days to allow use of 4G tablets, which were previously illegal for video appointments. So they're very much in support of it. And I think our shift on what we could use it for has moved since before the pandemic. So like I said, it was very much, this would be good for secondary care, and let's think of it from a hospital point of view. And now there's sort of a realization of, actually, there's a whole load of stuff you could do with it. Your hospitals is a really obvious one. You don't need to take people out to hospital. It's a much more dignifying process for them. It's, you know, much better quality. Hopefully your access improves. But actually, looking further afield, why couldn't you use it for primary care, for specialist GP clinics? You could pool staff resource across site. If you had someone, you know, who was a diabetes specialist, a diabetes nurse in one prison, why couldn't they do a special clinic for some others? Reception screening. I'm going to let Jake add loads more on this, so I'll just go over the headline categories. Mental health, we've talked about a lot. Telepsychiatry, assessments under the Mental Health Act before people are transferred to hospital, rather than having psychiatrists travel hundreds of miles to come and see a patient. You could do some of that remotely. Kate, I will leave again to talk about Through the Gate, and that's something we've been talking about, but I'll let her cover that. Again, substance misuse is something we're working on now, and how could you deliver some substance misuse services? We've even had dentists who want to be able to do some assessments remotely at the moment because they can't get into the prison. And then there's also the opportunity to access services that can be quite tricky to access. So very specialist services, which are tricky enough to access in the community, let alone when you're in prison. So things like gender dysphoria services, for instance, is really hard to access normally, and especially hard if you're in a secure environment. So why couldn't you do some of those appointments by video? So I think telemedicine has a huge role for the future, and people need to find their feet with it because it's new, and perhaps trying to squeeze it into the way you already do things isn't going to work as best. You might need to take a step back and say, okay, how do we change things and incorporate video to its best effect and use it where it's appropriate? But actually you could look across the sort of the gamut of health services and probably find some sort of role for most of them within it, meaning that you free up those resources for those that have to go out or have to be seen in person. And so it makes the service a little bit more equitable.
I think I would add to that with prison healthcare, in many ways we are, as I sort of alluded to earlier, many years behind what happens in the community. And digital technology is absolutely probably one of the key enablers for improving the quality, consistency and the equivalence of healthcare in the secure settings for us currently. And as Chantal has covered very well there, extremely wide range of uses rather than just the classical primary care, secondary care approach that we were thinking about earlier in terms of somebody going out to hospital to see somebody. I think I was talking to a doctor earlier today, a GP who works in a community, and we were talking about the flow of information from prisons and the continual complaint that they don't get enough information. He works with a practice of homeless people and who live in hostels or maybe live on the streets, and he recognizes that the only time when his patients might be sort of resident in one place is when they're in prison. And so, having not heard about telemedicine, I was talking to him about the prospect that actually he might be able to do sort of pre-release clinics with people prior to them leaving the prison, and do some catching up with them and assess the needs, and start building that relationship with them before they get out. So I think as we talked about earlier, that bridge between the prison and the community, and how can we break down some of those barriers, and I see telemedicine as an absolutely vital way of being able to build those relationships and break down those barriers before people leave.
Yes, to pick up on that. So we've been working with Chantal as well around Reconnect services and what can we do via telemedicine, particularly within the pandemic period. But that's given us the opportunity, but this will obviously continue after, to access services. So most people don't realise on the day of release, someone can have 5 or 6 appointments. So they need to go to the probation service. They might get released at 9 o'clock in the morning. They might have to travel 50, 60 miles via public transport. They have to go to a probation appointment. They might have to go to a substance misuse appointment. They might have to register with a GP. They might have to go to the housing service, the council, to register as homeless, or go and meet someone to pick up the keys to a flat. And actually, all of that, when you've just been released from prison, when you've had all your needs met, is really, really difficult. So we're looking at actually how can we utilise telemedicine to mean that we don't need to do some of that. So substance misuse is a prime example. That could be potentially done remotely before someone leaves the prison. We've had discussions around utilising the same technology for homelessness referrals and housing appointments. And really, now we've demonstrated that it can be done, that you can change legislation in 4 days, you can get this in there into the prison. The possibilities are endless. I think we should stop seeing prison as a different community behind a wall. It's part of our community. It's part of offenders. They might be prisoners one day, but the next day they're just the person standing next to you in the supermarket. So anything that we can do in the community, we should be able to do within the prison. Might have to do it differently, but it can be done, and it just takes someone to think about how that can be done.
I think one of the limitations with all of this is the practical side of things, and that's something that we've really had to confront during the pandemic. So this is more kind of trying to use, whether it's telephones or the local prison television channel or anything like that, to try and reach people during the pandemic, where we can't actually see everybody we want to see, and we can only see the most risky people and things like that. And even using telephones to speak to people became an absolute impossibility, because you've got people sharing cells who won't talk about confidential issues around a cellmate, and you've got the prison phones being recorded for security, so there's suspicion around that and mistrust around that. We're kind of operating in these kind of Victorian buildings that are not fit for purpose for these modern day things. And as much as I kind of look at it and go, yes, absolutely, this is definitely the future. I used to be involved in kind of trials for online interventions that are therapeutic. I'm very pro all this kind of thing, but it's going to take a real shift, I think, from the prison service side as well, to really kind of get everything fit for purpose in the first place. We're lucky if our computers work for an entire month in the prison at the moment, let alone anything else, So there is a definite kind of practical limitation there that definitely needs to be addressed from the prison side rather than the healthcare side, I think.
Jake and I wrote a piece on this with a couple of others about digital equivalents, as we called it, and the challenges around that. And there definitely are some. So for an example, we have a video system, a video software that is approved by HMPPS, and it's approved because it has very strict controls around it. So everyone who uses it has their own login, and you can audit exactly who used that system in case anything ever went wrong or ever got misused. And that's really important to them. Now, in the community, the hospitals, a lot of them have adopted video consultations for the pandemic, which is great because that opened their enthusiasm to use it, because before that was a little bit of a pushback. But what it's meant is a lot of them have adopted software that purposefully is very easy for anyone to access and does not hold any patient identifiable details. And we can't use those in the prison because they don't meet the HMPPS rules. And when you go to hospital and say, please, will you do this? Will you use our software? They say, oh, why? We've already got one. Why can't you use ours? And so there's that balance again, coming back. So we've got to stick with the rules. And don't get me wrong, the digital teams at HMPPS have been absolutely fantastic. They've moved at such speed. They've been so responsive. I think they've been a tremendous help in getting this all off the ground. But unfortunately, they're as bound by the rules and what they can approve as as you are in terms of what the NHS will approve in terms of governance or accountability of software. So yeah, that can be tricky.
I think from my perspective, where prison IT systems, clinical IT systems came into being in 2009 and 10, there was very much a great suspicion that this is somehow computers owned by that NHS organisation, and that was very much seen as a risk. And obviously, that, as I say, they've been in there for 10 years without really any significant issues. And I think this pandemic and the opportunities it has presented, obviously the work of Chantal around telemedicine, but there are actually a number of other benefits that we've seen. So the rollout of purple visits, which obviously is not a healthcare intervention, but it's another digital technology that has been brought into the prison estate to allow people to have visits with their families, especially in current COVID times when they can't travel, they can actually have those visits from their home. We're seeing the digitalization of the person escort record. So that's the piece of information that flows with somebody when they move between those various criminal justice settings I mentioned earlier. And actually, the biggest one for me, of course, is the clinical IT system that we use. System 1 will be connecting up with community GP practices, both to allow information to flow in and indeed to flow out to those community practices. So all of a sudden, we've reached a critical mass with all these digital technologies supporting us. It's not just the one thing. So all our hopes are not pinned on telemedicine or the clinical IT system, etc. It's a whole host of things that are coming together. And I think as these as they do come together, we'll see some real change, because I say it's a critical mass feeling to me. We've got some real momentum behind it.
Thank you everyone so far. So my final question this evening, perhaps maybe some of your final thoughts, would be, what do you see for the future of secure setting and prison healthcare? I know we've discussed quite a lot about ensuring equivalent standard of care for individuals and things. So I'd just like to hear your summarising thoughts for the future.
Well, I'll go first. For me, there's a couple. I'm going to take advantage to take 2 points. So one is around the fact that prison is seen as part of the community, as I said earlier. So it's part of the wider healthcare system, so that people don't separate it off. And I think that will absolutely help with the workforce. People don't think about coming and working in a prison. I don't know anyone that's gone to medical school or any other school because they want to be a prison GP or a mental health nurse in a prison. But actually, if we could see it more as part of the community as a whole, and people had to be offered opportunities to do rotational places, to come and work in prisons and potentially work sometime in the community, one, that builds better bridges for the continuity of care for patients, but also it increases the workforce as a whole and provides a much more community feel to the services, rather than, well, they're over there, they don't matter to us, that's not part of my service. So for me, the future is around more integration, improving the pathways of care, and working together. And also for me, we're going to pass out the things that we do really well out into the community, the multidisciplinary working, the health and wellbeing approaches, the person at the centre of the treatment of all different types of medicine, working together for the one patient in not quite harmony, but together anyway.
I think I would echo that from Kate. I think. Oh, sorry.
No, you go.
I just say I would say that exactly sums up exactly what I would say as well. I think that the them and us is tricky, and it really is. And again, within the research I did around telemedicine, and to understand why it took so blooming long to get it off the ground, there was a lot of them and us between the hospital system and the health and justice system, and then the providers and the prison who sat in the middle, and they needed to kind of be brought together. They didn't sit on any of the shared forums. There needed to be dialogue. It needs to be, it's not just your patients over there. There are patients, there are citizens in the community. We need to be treating them the same as the others. So I think that is tremendously important. I think also just keeping in, like I said, like Jake said, the equivalent pace within the community, not necessarily just focusing on telemedicine at all, but on digital equivalents. You know, as people get enabled to self-care, they have, you know, remote sensors or dementia equipment, or, you know, wearables that help them, frail people, to stop them from putting them at risk of falls, etc. Things like that. Again, it's a whole new conversation within the prison system. But if we're enabling people to look after themselves much more in the community, you want to kind of be able to keep pace and enable that within these environments as well, and not put people at a disadvantage.
I think I'd like to see, more than anything else, probably a broader adopting of the trauma-informed approach, definitely. And along with that, it being more than just equivalence. I think the populations we're dealing with, as we've discussed before, are generally not engaged with services on the outside a lot of the time. They often have low literacy, they've got very traumatized backgrounds, they come from deprived backgrounds. And I think we need to go beyond equivalence, actually. I think we need to be providing something above and beyond what is provided in the community, so that when they do go back in the community, they're able to function in the community in a healthy way, where they can access services easily, and they can access the services that are available in a way that is helpful to them, rather than it being, okay, here's the service, but that's not the service that suits me, and I need something a bit more than that. And I think it's really, really important when taking that trauma-informed approach that we're thinking about staff, not just the prisoners or residents or service users, because that gets neglected a lot, I think. And working in a prison is an incredibly challenging thing to do. And we need to think about the trauma that staff are constantly exposed to, whether it's direct or indirect trauma, and supporting them to be in prisons so that they do want to work in prisons, and are able to tolerate that as a role, and can be healthy and happy individuals themselves. You know, it can be quite an institutionalizing place to be, and I think you'd require far more support, not only as a prisoner but also as a staff member in a prison.
I think if we're talking about ambitions and what we would like to see for the future of prison healthcare and secure environment healthcare, and I think taking on Radha's point a little bit further, it's actually recognizing or having the wider public recognition that actually investing or increasing the investment in healthcare services in prison settings isn't just an investment in those people. It is an investment in the community more widely, as obviously Chantal and Kate have already alluded to, and what we have heard often is the community dividend in respect of that. So, you know, we recognize that people who stop smoking in prisons may stop smoking when they leave prison, or because they've had their substance misuse addressed better this time round, that they're going to engage better with their families when they're out in the community. So how can we continue to build on that and achieve those better health outcomes? Because really that's what equivalence is about. In fact, if we look at the definition, it's about doing things differently, or politically incorrectly to say that they're better in prisons. Shouldn't really say that, but the intention is actually to achieve those equitable health outcomes and actually to improve society as a whole.
I think one thing I'll add to that as well is borrowing the words from Dr. Al Story, who's at UCL with me and runs the Find and Treat, and will often talk about people having states, not traits. You know, homelessness is not a trait, it's a state that you're in at a time, and actually recognizing that people in prison are often the people who are in the community, those really complex patients you have to deal with out there, the ones who are homeless, who have the overlapping, as we've said, problems, maybe substance misuse, mental health, domestic abuse, etc. And recognizing that being in prison is just one of those states at that time, but by helping across in and out of the prison, you're helping this incredibly complex group. It's not prisoners, and it's not people in the community, and it's not the homeless. It's actually it's all one group that unfortunately often moves between these different states and stays perpetually in, you know, a state of poor health. And actually we need to invest inside and out in getting those people out of those states.
Yeah, I'll just finally say, building on that, you know, that people, we need to really believe. We send people to prison to rehabilitate them, not to punish them. You know, it's a punishment, but also it's an opportunity, and we need to believe that what we are doing is helping people. And then when people are rehabilitated, we need to give them opportunities. We need to be able to engage with them, get their lived experience to help us improve and better services. And you know, that's one of the areas with telemedicine has been really fantastic, because where we couldn't get ex-prisoners back into prisons, we can via telemedicine. You know, they don't need to set foot within the door. So for me, it's something the future is about building upon what we've already got, using those who know best to change and adapt our services so that they really do meet those needs and help people to have equivalent health outcomes.
Okay, I'd like to finish this HLA Live episode by thanking all of our panellists which have joined us this evening, and goodbye from us now. Thank you.
Thank you to everyone that made tonight's episode possible. Whenever our scholars are thinking about complex problems facing our health systems, we encourage them to think about how they make significant change in the world of healthcare. We are incredibly lucky to have some incredible scholars in the HLA. They use the HLA as a platform to take their ideas and bring them to fruition. If you are interested in the work of the HLA, why not join us at one of our future HLA events? Why not join one of our programs? Why not even become a HLA scholar? Thank you for joining us. My name is Johan Marlwaner, the Director of the HLA, and it's a good night from all of us.